Hello, my name is Simon Cook. I'm a criticalist over here in the UK, and welcome to this VetLit podcast. VetLit Minis are journal club podcasts on a range of topics, small animal focused, so you can keep up to date even if you just have a few minutes spare. Joining us today to discuss sedation and anesthesia, perhaps particularly in the ER and the ICU, with relation to the new anesthesia and sedation monitoring guidelines from the ACVAA, is Dr. Lydia Love. Dr. Lydia Love is one of the lead authors on the 2025 Small Animal Anesthesia and Sedation Monitoring Guidelines, published in Veterinary Anesthesia and Analgesia, and is a clinical associate professor in anesthesia and analgesia at North Carolina State University. Thank you so much for joining us, Dr. Love. We really do appreciate it.
Oh, I'm super excited to be here and talk about these guidelines and anesthesia generally.
Excellent, excellent. Now, I suppose to start with, we can't really do the article itself justice in this format. So I'm going to ask Dr. Love to give us a bit of an overview of the contents, because there are perhaps some overarching themes that are really being emphasized. And then we've picked out a few ECC topics to dive into in a little bit more detail, because it was too good an opportunity to miss having Dr. Love here. So we're going to talk about things like hypothermia, the recovery phase, sedation specifically, and then maybe we're gonna delve into urethral obstructions and septic peritonitis and see where that takes us. Maybe if I come back to the beginning and say, would you be happy to give us a bit of an overview of the contents of the guidelines and the things that you really feel were overarchingly important?
Yes, I'm really excited that we got these published this year, that we had the momentum and energy to do so. They were last updated in 2009, with the first edition being published in 1994. And so 2009, I mean, that's a pretty big gap. A lot has changed in veterinary anesthesia. And so having the ability to review the literature and use expert opinion to hopefully get some information out there about, what does safe anesthetic care look like? How do we mitigate the risks that are inherent in the bringing about of unconsciousness, right? When we bring about unconsciousness, we are on purpose poisoning the CNS and by side effect, poisoning all the other organ systems as well. And the only way to make that safe is to try to monitor and prevent and manage any cardiorespiratory side effects that occur. And so the monitoring guidelines are all about that. How do we think about what could happen, monitor for it, and we tried not to stray too far into being a teaching document about management, but we
Yeah.
did mention here and there. And then our hope is that people will, go to other resources to really dig deep into, well, when an animal becomes hypotensive, what are my options? The big things I think that are themes within this document that are really important to me include, number one, and I'm going to ask you how you feel about this, Dr. Cook, having a dedicated anesthetist. From my perspective, if we are distracted, if our attention is divided, it is really hard to always see what's going to happen, to see what happens before it happens. And that's when we can take care of things more easily, more safely. So, from my perspective, that's one of the most important things in this document.
Yeah.
Have someone who is dedicated and well trained paying attention to the animal. Is that something you're able to do in your setting, or have you been in settings where that doesn't always happen?
Exactly. It's a formal requirement from in my setting, but that formal requirement was only a recent, very specific recommendation or very specific practice. It was always something that we aimed to do, but now it's very much something that we have to do, we must do for anything that is any patient that is sedated. But I suppose what I quite enjoyed in these guidelines as well, specifically, is that you make a case or you discuss the concept that that could be anything from a board certified anaesthetist to, for example, in different settings, a well instructed and well supervised clinical veterinary student. Ultimately you're saying there needs to be somebody, and there's a big spectrum possible for having somebody that can be totally dedicated to that sedation or to that anesthetic.
Yeah, well, the reality is that we work within teams, right? And often the veterinarian is the leader of that team, but we need to use the resources around us as an extension of ourselves. So, I mean, I think I'm in a setting that is really amazing because we have veterinarians and really highly trained veterinary technicians and veterinary technician specialists who are able to, be anesthetists.
Yeah.
But that isn't true in every setting.
Yeah.
And I think we can still do a good job by using the resources we have, training people, making them knowledgeable, empowering them, teaching them about good monitoring supportive care, and then working together, as a team. Obviously, this is going to be dictated a little bit by your jurisdiction, right? Like, so the
Yes.
rules, the laws are going to be different. And in the US, there might even be different state to state about who can induce anesthesia, who can monitor anesthesia, who can do local regional anesthesia, et cetera. But from my perspective, we are better together.
Yeah. Totally agree. The other idea that it's perhaps worth conveying now is that a lot of the guidelines were divided to demonstrate that spectrum of what you may or may not be able to offer into minimum, alternative, and advanced techniques for monitoring the patient in one of many, many areas. So broadly, the article included recommendations with regards to monitoring the depth of anesthesia, monitoring circulation specifically, oxygenation, ventilation, etc., and dividing the recommendations into different levels, I suppose, depending on the setting that you're in.
Yeah, I mean, even in human medicine, depending on where you are in the world, care is contextualized by our financial resources. And so that's a serious reality in veterinary medicine. And just because we don't have all the resources in the world doesn't mean that we are not interested in still taking really great care of our patients. And so what we wanted to do was provide recommendations where we were able to say, here, in a pretty healthy animal, in a moderately resourced area, here's what we think is really minimum to provide good patient care in the peri-anesthetic time period as far as monitoring goes. But again, we don't all have that
Yeah.
luxury. And
Yeah.
so we tried to provide some alternatives when those things aren't available. Now, I will say in many higher resourced areas, more highly resourced geographic areas, oftentimes people have multi-parameter monitors now. They just buy the whole thing. They buy it all. And there's a lot of value in utilizing those parameters, learning about them. If you have end-tidal CO2 and you haven't quite gotten a handle on all of the information it can give you, this is a real opportunity to say, you know what, I'm gonna apply this and hopefully provide, really great care. But if you don't have an end-tidal CO2 monitor, because capnography is on the expensive side, there are other things we can recommend to monitor ventilation to help keep that animal safe.
Yeah. So then if we moved on to a couple of or a few of the themes, we picked out some that I thought were just gems that you can share with us. And the first one I was going to pick your brains on was hypothermia. Why we should be so actively avoiding it, and your maybe my question would be the easiest ways for us to not lose those first 1 2 degrees, perhaps the easiest ones to lose. Do you agree?
Oh, yes, yeah. So with general anesthesia, we vasodilate them. And within that first 30 to 60 minutes is the biggest drop in temperature because of the redistribution of blood from the core to the periphery. And then the four mechanisms of heat loss, radiation, convection, conduction, and evaporation happening all the time. They just happen faster, right? And then you also don't have behavioral responses like shivering and burrowing to get warm because of course you're unconscious. And so you lose a lot of heat in that first 30 to 60 minutes. It slows down a little bit over the next few hours. And then if you do nothing, they'll settle out pretty low. We're talking, oh gosh, I'm of course American, so 92 degrees Fahrenheit, which is probably going to be around 33 centigrade.
Okay.
Might
Yeah.
need some help there.
I don't, if I'm honest, I don't know. So I might just
I
take
know
your word
that
for that.
I know that 37 is 98.6 and 40 is 104. but I'm not sure
Plenty.
of the other way. But so anyway, hypothermia is a big stress, right? Like you can think about the triad of death: hypothermia, acidemia, and coagulopathy. Like I don't want to get into that triad. And it's easy enough to think that hypothermia is not a big deal, but it is a metabolic stress. And then if we don't, warm them up, if we let them get cold and then we don't warm them up, now they got to warm themselves up. And that's a huge metabolic cost. It's a huge increase in oxygen consumption at a time when they might still be hypoventilating from general anesthesia. And, a healthy animal can take that hit and bounce back okay, right?
Mhm.
It's unpleasant. Nobody likes to be cold. When they become conscious of it and they're shivering and it's probably a terrible feeling.
Mhm.
But they can probably bounce back. But an animal who's on the edge, maybe unstable to begin with, and you then give them that other metabolic push, maybe that's something they don't bounce back from as easy. So, so how do you keep them warm? Well, we all have our favorites. What I would say is that the anything that goes in the microwave is unsafe. I've seen too many burns, and the resources we have available us to keep animals warm are relatively attainable enough that I would not use anything I would put in the microwave. Um, you can certainly do passive insulation. And there are some recent studies that show that that can help somewhat. So even going as far as wrapping the limbs
Yeah.
with bubble wrap,
Yeah.
and baby socks, and never place an animal on a cold metal table without insulation between it. Just that passive insulation can go a long way. You talked about how to prevent that first drop. We don't have great evidence for this in veterinary medicine, but it does it definitely is supported by the human literature, and it just makes sense. Pre-warming, whenever possible, can help prevent that first drop. So, like if you were going to have an anesthetic procedure, you'd be in the waiting area under a bear hugger before they got anywhere near you with drugs. Now, you don't want to cook them by accident ahead of time. But putting an animal on a bear hugger for a half hour while you're pre-medding it and sort of getting everything going can really help decrease that gradient so that they don't lose heat quite as quickly. Now, it doesn't work to just do that and then do nothing. They'll still drop incredibly. So you got to keep it going.
Okay.
Resistive blankets like Hot Dogs or the brand we have in the United States are also very safe and reasonable. And then, like in the ER, I'm sure you sometimes use internal active warming. So occasionally, like if an animal, I don't know if it gets cold enough where you are for like animal falls in the lake in the winter and they're, very cold, but like
We
you might infuse warm fluids into the bladder or the colon, or certainly during surgery into the abdomen.
I would love to have more of those type of cases, but
Oh,
the
no.
sad truth is we don't get them.
Oh,
We learn a lot about them and we learn how to manage them, but rarely do we see them. They sound like really cool cases.
yeah.
And
Well, they say they're not dead until they're warm and dead.
right, yeah, I totally agree. And then maybe if we moved on to the recovery phase, what are the reasons that we emphasize that so much as being a key time frame in which you can make really important interventions for the safety of our patients?
Yeah, well, the largest prospective small animal anesthesia mortality study we have came out of the UK about 20 years ago. I think my numbers are right here: 98,000 dogs, 79,000 cats, 117 different types of clinics, both primary care and referral practice. And that study indicated, so it's called the Confidential Inquiry into Perioperative Small Animal Fatalities, that I think 61% of cats and about 48% of dogs, so right at 50% or just over, of anesthesia-related deaths occurred in the first 3 hours post-anesthesia.
Right.
So I think of recovery in three phases. So we often talk about the time from turning off the gas till extubation, the recovery. And if someone says, like if another veterinarian says recovery was prolonged, they often mean that time.
Yeah.
But then the really dangerous part actually is that secondary phase from the time they were extubated until they're really taking care of their own life,
Yeah.
till they get their physiology back under their own control. They're warm, they're ambulatory, they're oriented, they're pain-free, they're nausea-free. and ready for discharge. And that's the point where things sometimes go wrong. And, our routine is okay, anesthesia's off, taking off the monitors. I'm going to disconnect them from the machine. All right, go ahead. It's yours. It's your job now. You do it. You do it. You take care of yourself. And that's a big transition. And sometimes that transition doesn't go well. And so keeping an eye on them in recovery is one of the most important things we can do to keep them safe.
Perfect. And then I suppose, what does that look like? Is that ultimately having the patient on something visible, even if you're not immediately beside the patient, some kind of visible output for their stability, ECG monitoring, etc.?
So I think minimally visual eye contact, right? Like that, like, putting them in a cage around the corner might not be the
Hmm.
best thing when they're still under the, influence a little bit, or putting them back in the kennels. So minimally, I think visual eye contact. And then I think it depends on the patient. So, and how long it's been. Certainly in the first 10 to 15 minutes, I'm probably going to keep a pulse oximeter on them if I can, to make sure that they are not causing themselves to be hypoxemic from continued hypoventilation while they're on room air.
Yeah.
And then there are some patients for whom I might leave the ECG on, or, I have, sometimes we'll put a little nasal prongs in so we can get in tidal CO2 in those animals, or an approximation thereof.
Yeah.
Our patients don't always cooperate all that well, right? And there are certainly going to be animals who will not tolerate these devices for very long. And I think in that sense, at that point, just visual eye contact goes a long way.
Yeah, absolutely. And I suppose you've also got the idea of scale of your operation as well, right? Isn't it amazing to be able to have dedicated recovery areas and staff, etc.? I'm guessing
It's
that's something that you,
amazing. We just
yeah.
started a post anesthesia care unit. So instead of taking, like, in the past year or so, and it's been such a blessing to have the most of the patients who are going to ICU often go to ICU, but instead of going to our step down wards or general hospital, our post anesthetic care unit, or PACU, they're all there. I can check on them. We can make sure they're pain free. We can give them more anti-nausea drugs if they need them. We can make sure they're, keeping
Yeah,
themselves, their physiology together. So it is awesome.
perfect. So then the third topic that I'd hoped to talk about today was sedation, because that's specifically addressed, and it's perhaps perhaps there's a spectrum, isn't there? There's a spectrum between sedation and formal general anesthesia, and whether we recognize that spectrum enough. And I suppose I've chosen the urethral obstruction cat to think about, because to me that really demonstrates that spectrum, because you'll have people that choose to sedate, you'll have people that choose to generally anesthetize, and there's probably a good proportion of those patients that are sedated could be classified as formally generally anesthetized. What do you think about that as a topic?
Yeah, I mean, I think you're spot on. This sounds flippant, but there really is a continuum from fully awake to fully dead. And what we're aiming for with anesthetics and heavy sedation, is we're aiming for not responsive to painful stimuli, but ventilating well, oxygenating well, maintaining their cardiac output, forward blood flow, oxygen delivery, et cetera, et cetera. And the thing is, it's hard to dial that in. Like, I can't tell you exactly what's going to happen when I give a dose of drug. And I think we actually make it harder on ourselves sometimes as veterinarians by not being willing to put in catheters. I'm going to give this IV off the needle and go do this procedure or take this radiograph, but I got to give him a big old dose because he really isn't happy to be here, and I don't want to have to hit his vein again. So then that gets even harder if you don't have a catheter and you can't titrate carefully to effect. But even when you can, which is one real advantage of having an IV catheter, and the other being, like, if things go wrong, you can give emergency and rescue drugs IV immediately. But even if you have a catheter and you can titrate drugs, I can't always predict what's going to happen. I have a pretty good guess where I'm going to go, but an animal may absolutely kind of cross over that line. That line is too fuzzy between heavily sedated and taking care of their own life, and then actually anesthetized and maybe not protecting their airway.
Hmm.
Actually anesthetized and really not ventilating well.
Yeah.
And so I think that's where the monitoring should come in. That's where, if you're aiming to heavily sedate, you should at least have an IV catheter, supply O2, and keep a pulse oximeter on them. And then pay attention. If they're not oxygenating well, if they're not appearing to ventilate well, um, then intubate them. Then go ahead and do the thing. Even if you're like, oh, he's just heavily sedated. Now, I do think cats are a little bit funny in that, cats have a very sensitive trachea. I think you need to be really careful when intubating cats. You don't want to intubate a light cat. And I do think you want to make sure that whoever you have intubating cats knows what they're doing, right? You can tear a cat trachea if you're not careful.
Hmm.
So I do think there are settings where the risk benefit calculation of intubating a cat may fall on the side of not intubating it,
Hmm.
again, depending on your resources. But if they're not oxygenating well, if they're not ventilating well, then you probably need to go ahead and control their airway.
Yeah. And I suppose we'll steer clear of specific recommendations because every patient is very individual, isn't it? Especially in the urethral obstruction cases, there's a massive spectrum of severity and instability in those patients as well. So, and there are a lot of opinions on whether these cats should be sedated or anesthetized, but we don't have any formal evidence to say one is better than t'other. So I'll
Here's
just,
where I do have some opinions.
yeah, this is where I was going to
I
go.
actually think for the most part, in 95% of the time, the drugs don't really matter. They're all bad. They're all poisons. And how you take care of the patient is more important. And for a urethral obstruction cat, I am much more interested in what his potassium is and what his calcium is, and potentially, what his creatinine is and hydration status than I am whether you decide you're going to use propofol or midazolam. Now then, I would not do a total IM kitty magic kind of approach on a sick cat
Hmm.
no matter what. But
Yeah.
there are some UO cats who are not hyperkalemic, who are early on. You can do a IM induction, DKT situation, um, and then you got to take care of them. So dexdomitor, ketamine, and butorphanol. And in the US, it is commonly referred to as kitty magic. In the UK, you have a quad protocol, which is that plus midazolam
Yeah. Yeah.
for spay neuter, high volume spay neuter. So some kind of IM induction to anesthesia where you've got an opioid, you've got typically a dissociative, and typically an alpha 2. So there are blocked cats where that would be okay. That's a really common way to handle cats because people don't, it's just easier to knock them out and put a catheter in, or knock them out and neuter them, than it is to IM pre-med them, place a catheter, IV titration to effect. Like, cats don't always cooperate. So a lot of cats get IM inductions, at least in the United States.
Yeah. Yeah. Okay. And do you see much either at your institution, or are you aware how many people are using things like sacrococcygeal epidurals in these cats?
Yeah, I'd say there's marginal penetration of the market with a sacrococcygeal block. I don't see them done a ton. Lots of people
Yeah.
talk about them,
Yeah.
but in the places I've been, for the most part, I think people find it easier to just IV drugs to effect and then unblock them. I will say when you get pretty slick with them, they're very fast
Yeah.
and they actually make catheterization easier.
Yeah, I mean it's one of those things that I often just forget about, but when I remember to do it, I realize how useful they are. And yeah, they are very straightforward to perform, aren't they? So maybe I'll make sure there's a link in the notes to how to perform that because they're really quite handy to have in your armory.
Yeah, and they're pretty safe to try. They're pretty safe to try to learn. I mean, I can understand the hesitation with the lumbosacral epidural. You might hit CSF in a cat, but with sacrococcygeal, there's not a lot to hurt back there. Certainly risks still, you could hit a venous sinus. I haven't doing that, but you could
Mm.
you could cause an infection if you weren't, aseptic in your technique. But in general, they're pretty safe to try, and sort of one of the most common side effects is that it just didn't go where you thought it was and it didn't work.
Yeah, yeah. Okay. Well, yeah. I'm glad we've considered that spectrum because it's a contentious one, isn't it? There are a lot of opinions in that space.
Yeah, there are a lot of opinions. I actually would ask you, how do you feel about my statement about the hyperkalemia? Like, I do not think you should anesthetize a cat or a tiger or a foal or a dog with a potassium over about 6.5. I'd prefer it to be under 6. I'm going to get that potassium down before I give it any cardiorespiratory toxins. So
Yeah,
that's my controversial statement.
yeah, okay. Well, I would probably start by saying we often would we often would sedate a patient with a potassium north of 6.5.
I think, listen, I think you can get away with it if you do a little bit of calcium. You probably can get away with it if you go ahead
Yeah.
and give some calcium. But it is so easy to get potassium down. You just give them some terbutaline. It's fine.
Yeah, yeah, yeah. So
And then
then
their potassium's 5.8 and you can feel great.
so I suppose it brings into the debate how aggressive you want to be in trying to lower that potassium. If you're just going to go so far as using chemical interventions for dropping a potassium, my next question would be, do you document that it's low, or do you just assume that you've made an intervention? Because to me, there is a scope for that. There is a scope for saying, right, I've got a potassium of 7 or 8. I know I can make the cat more stable with a bit of calcium in the background. And even if, based on a recent study, I'm not going to drastically change the potassium and the creatinine at the 4 hour time point, maybe there's a case that I will have dropped the potassium during the time point at which this cat is most critical. That's I guess the information that we don't have. And so to me, I'm comfortable sedating with a potassium north of 6.5, so long as I've got a plan in and I'm intervening, and that intervening could be anything from being a little bit more aggressive with fluids, giving some calcium, giving a token dose of dextrose, whether you want to follow up with some insulin as well. Maybe you're a bit more familiar with using terbutaline. We don't use that a whole lot in these cats, to be completely honest. But I'm happy to do it as long as I'm making some kind of intervention. But I don't necessarily track it because to me
No.
that might well lose resources and time when actually I've probably secured the outcome that I'm after. And
Yeah.
when I'm looking at a cat that I'm aiming to deobstruct, and I've got a plan basically for this process in the next half hour or the next hour, if I've got the facilities to carry on, that's when those sort of 20-minute concoctions and procedures do fit in.
Yeah, I mean, that's the thing that's going to fix it, but they are truly a metabolic emergency, not really like a surgical emergency, et cetera, right? Surgical is the wrong word, but an interventional emergency. They're a metabolic emergency. They're dying because of that potassium in the short term. And
Yeah.
so then giving more, you know, cardiorespiratory toxins on top of that. I insulin and dextrose are very good. And, then you got to worry about the blood glucose for kind of ever, it feels
Yeah,
like
exactly.
afterwards.
Yeah, yeah.
Whereas terbutaline, has some side effects as far as can cause some tachycardia and some acute vasodilation. But they bounce back from that pretty quickly and it's pretty darn effective. And you know what? Our patient population is probably a little bit different. I'm often, ours might be one who nobody could unblock and it needs a PU, or I've got a, blocked goat who needs a tube cystotomy, or I've got a, ruptured abdomen foal or something like that. And those are ones where like it's gonna take a while also in my setting, right? So it's not gonna be a 15-minute procedure where I can give some calcium and just keep my fingers crossed and keep my eye on the ECG.
Probably it comes down to those timings, doesn't it? If you're imagining a patient that you're making an intervention on and using a drug or an intervention to drop the potassium, and you're also expecting this cat to be deobstructed within the next 20-30 minutes, it's quite different, isn't it?
Yeah.
So probably that's what we're both saying.
Some of the most stressful moments I've been in
Yeah,
are hyperkalemic animals
yeah, yeah.
who are under anesthesia, who are anesthetized. And whether that's because now it's a surprise. So for one, like I had a cat who needed a PU. This was years ago now. And this was in a private practice, it just took time, right? And so he came in fairly stable. When we anesthetized him 3 hours later, oops, now
Yeah,
his potassium was 8, which we didn't figure out until he was acutely bradycardic and very scarily so.
yeah, yeah.
That was my learning curve. Like I should have checked, absolutely should have checked before anesthetizing him, and I know that now. And I wouldn't have anesthetized him. I would have fixed his potassium first, but
Great. Yeah, yeah. So could I ask you on a ECC ER presentation, could you talk me through your appraisal and your choices of drugs or procedures that you put a patient through that has just been diagnosed with septic peritonitis and is going to be going to theatre in the next short while? What does that short while look like to you?
yeah. Well, I guess that short while depends on what the patient looks like, right? So has the patient been volume resuscitated appropriately? What do I think their contractility is doing? Do we know what their lactate was 2 hours ago and now? Is it
Yeah,
higher? Is it lower? Like, what are their electrolytes? What's it? All the things, all the things.
everything.
In particular, I think with them, volume, contractility, and blood pressure. Um, how have we resuscitated the animal? Obviously, hopefully they've gotten antibiotics already, even before source control, like within the first few hours of presentation. I'm going to try to make that happen. I think that we as a profession have gotten a little bit too restrictive with fluids sometimes prior to anesthesia. And I definitely learned too liberal,
Yeah,
but
yeah,
I do think I sometimes have patients who come to me who are just barely keeping it together
yeah,
because they just haven't quite had enough fluids. And then I poison them and then it falls apart.
yeah,
So I'm going to do what I can, and I am still learning. But to try to evaluate with my ultrasound, what do I status is like? What do I think contractility is like? What do I need to manipulate there? And then during anesthesia, fluid volumes, I'm going to try to assess with dynamic parameters, right? So
yeah,
things like PVI. I don't have transesophageal echocardiography available to me, but I can again try transthoracic to the best of my ability, and try to what can I do to stabilize this thing as much as possible before I push it off the homeostatic cliff?
yeah. No, I completely recognize that population of patients that have been that haven't been volume resuscitated as aggressively as certainly we once might have, but certainly they could have been and maybe should have been. I do recognize that movement towards trying not to be overzealous. It's a really important direction that we've made a lot of progress in the last 5 or 10 years, haven't we? But
Yeah, it's
by
hard though.
virtue of that, we see the opposite end of the spectrum now, don't we? I think that's a really
A little
yeah,
bit, I think. And it's not like there's a magic way to thread that needle.
yeah,
I think it's a little bit trial and error and a little bit trial and error with each patient, a little bit like stimulus response. I'm going to try this. Did it work? But I do think thinking about total volume delivered and is helpful for me at least. How many mil per kg has this animal gotten since it hit the door? How
yeah,
many mil per kg did I give it? How many mil per kg has it gotten in the last 24? Where do I think it started?
yeah,
And then also just the things that I can do to assess, where it's at now. Like, has the lactate come down? Was it 14 and now it's 7? Okay, that's good.
great, yeah, yeah. And do you see, just to add on to that, do you see if it's possible to have a patient that we're looking to anesthetize and we haven't given enough volume? That's what we're saying. Do you also see the patient population that have had, for example, less volume resuscitation than you might have liked, but are also on a vasopressor earlier than we might have chosen by the same token? Do you see that
Yeah,
too?
I do think that happens in sort of both the ECC setting sometimes before we get them, but also in anesthesia because as a group, we're
Yes.
all kind of like, oh, you got to be so careful with the fluids. And so people are fairly quick, I think, to go to sympathomimetics, which is fine. And sometimes you get a signal that that is maybe too quick. Those patients often will not respond well to the sympathomimetic and often have, maybe they become tachycardic or they even develop ventricular arrhythmias. How I've like an analogy that I like
Mm.
to think about that I've heard described in regards to that is, you start putting your foot on the gas pedal, right, with the sympathomimetic. You're like, you're going to rev the car, but you haven't filled the tank up. And so then the engine's like, oh no. And you get all tachycardic or you have these VPCs or whatever. And so if that happens and pressures aren't still going great, then I try to take a step back.
Yeah.
Like, hey, we need to try this fluid thing again.
Yeah, cool. That's a really cool observation. Thank you. I enjoyed that. So I've got one or two more questions that I'm going to propose to you, Dr. Love. Could I ask you your three locoregional anesthesia techniques that the ICU or the ER vet would do well to have in their armory?
Yeah. Well, I think the sacred coccygeal block that we talked about, I think can be really helpful, can help you decrease the amount of systemic drugs that you need to give to a patient who may be pretty unstable. And sometimes a little bit of an opioid and a sacrococcygeal block, and you can get it done. So that would be a really good one. A couple of other ones that I think are, just easy, off the shelf. Putting local anesthetics in wounds. So surgical wounds in the abdomen, putting it in there like it's Nocita. I don't think y'all have liposomal bupivacaine in the UK. But there is a product called Nocita in the US. The human version is Exparel, liposomal bupivacaine. In the human version, compared to saline, it's great. It decreases pain scores, it decreases opioid requests. But when they take the same product and compare it to regular old bupivacaine used in the same way, the difference is really marginal. So if you have Nocita and you want to use it in the wounds, in abdominal wounds, do it. But if you don't have Nocita, you can do a pretty darn good job of decreasing analgesic requirements and pain scores by just putting bupivacaine in all layers of the wound as you close. So I think that's simple, it's easy, it's cheap, it's available to almost no matter where you are. So
Right.
that's a good one. And then maybe a little outside the box, um, things like TAP blocks, so transversus abdominis plane blocks. They're ultrasound guided. You put the local anesthetic between the internal abdominal oblique and the transversus abdominis, and all of the nerves for the body wall and the peritoneum run through there. That can be really helpful for abdominal procedures. And then also, to a certain degree, for things like pancreatitis and other
Okay.
painful abdomens. There are some other blocks that probably get the sympathetic trunk and then therefore get the visceral nerves a little better, but those are kind of even more advanced blocks. Um, the other thing I would think about that's really easy, and I know this is four now, is intercostals.
Yeah.
So intercostal blocks for rib fractures, if you have multiple broken ribs or a flail chest, they're super easy. They're really cool with an ultrasound. If you have a linear transducer, you can pop it right there real quick, but
Right.
you can do them blind. Just come right down on the rib, walk a little bit off the back, aspirate and inject. And those animals, it's a world of difference
Yeah.
for them.
I feel like they're another one that I essentially I forget about all the time. So tell me, do you think there's a place for them when we've got procedural, interventions that we're making in a non-surgical patient, or do you think they're reserved for the patient with rib fractures and having surgical procedures of the thoracic wall, or do you think there's a place for them in some of the procedures that we're doing on our patients?
Yeah, no, I think potentially, I mean, usually with things like thoracocentesis, I just put local anesthetic at the needle site. But the problem with that, of course, is then you put it and then like, where did it go? And then my needle's
Sure.
like, 2 centimeters to the side. And those situations are also often maybe a little bit time sensitive, right? Like I got to tap this thing pretty quick. And so potentially messing around with an intercostal block and waiting for it to have an effect might not be super helpful, but maybe if you could have had a more planned time period, that could be done.
Yeah, yeah. So a less emergent state and
Yeah, you got a
maybe
little
a
warning.
yeah, and putting a drain in, for example, maybe even there's a place for them
Yeah,
there instead of a
yeah.
synthesis. But okay, great. Well, thank you so much.
Oh,
What I'll probably end with is saying, is there anything else that you specifically wanted to have addressed or think we haven't covered or afterthoughts, anything that you want to add into the mix at this stage?
yeah, I really just would love to impress upon people that anesthesia safety is not about picking the right drug combination. the drugs all have cardiorespiratory side effects. None of these are therapeutic per se.
Yeah.
Like none of them, nobody's there specifically, other than sort of analgesia. Nobody's in the hospital because we're going to give them propofol, right? They're not there for that per se. Now, the exception to that is, a quote unquote medically induced coma, right? Anesthetic drugs are not therapeutic. And so, picking the right drugs, like you want to be familiar with the drugs you're using, you want to know what the side effects are, but most of the time it doesn't matter which poisons you pick. What matters is how you take care of the patient. And you know what they need by monitoring them. And so just pay attention to your patient. Use the resources you have. Empower your staff and yourself to intervene when needed and work together as a team to make it better on everybody, right?
Yeah.
It's not fun when anesthesia doesn't go well.
I think that the terminology you're using is conveying that as well. You're intoxicating your patient. Poisoning. Sorry. Yes. Yeah.
It's
Yeah.
I mean I talk about it that way because it's like sometimes the medical words obscure what we're really doing.
Yeah.
Right?
Yeah.
And
Yeah.
like when you use lay language, like if I were to explain this to my non-medical relative, that's what we're doing.
Yeah.
Unconsciousness is an abnormal state of the brain. We have poisoned the CNS to reach that. And in doing that, we are poisoning the heart and we are poisoning the lungs and we're poisoning the kidneys a little bit. Like
Yeah.
it's not a therapeutic state per se. It's amazing and it's so cool. Like, what is unconsciousness? What is consciousness? I don't know.
Uh,
But
that's something for a different podcast, hey?
yeah, for sure.
Okay. So I think that's about everything for today. Thank you so much for joining us, Dr. Love. What I'll say is the aim of VetLit is to make veterinary literature both more accessible and more accessed, and hopefully we've secured that in some small way today. You'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back there, here, or via the email updates for more, and otherwise have a great day. It's goodbye from Dr. Lydia Love,
Bye. Thank you for having me.
and it's goodbye from me. Bye for now.